Hey guys, can you see me, hear me? Hello everyone, how are you? Am I audible? Am I visible? If so, say me a hi. Okay, I hope most of you must have completed your theory part of your university exam, and I hope you must have done amazingly well. So I'm going to have four series for pathology practicals. I'm just going to be an extension of the same for everything what you have done. So I'll be discussing general pathology slides today. We have digital slides and also one or two points which is necessary for you to answer the exam. That's one. Second, tomorrow we'll have hematology classes. The next day, the third day, we'll be having systemic pathology classes. And the last day, we'll be having gross specimens, right? Because gross and microscopy is something which is a part and parcel of every practical exam. I am 100% sure you know what is the diagnosis by looking at the label. But still, let's go and read the right way possible and try to answer a couple of questions. I'll ask you, since your theory is over, I want you to answer few identification points for everything, one or two leading questions which might be required to write in the practical exam for everything, right? So if everything goes good, let's start. Am I audible? If so, just give me a comment. Hi, hello, good evening. Okay. So the first thing, I'm going to just show you a simple slide of fatty liver, right? Okay. Devshi, I hope you did well. For people who have not completed, this might definitely help you over the period of time, right? Okay. I'm just going to show you the slide of fatty liver. Can you see the fatty liver? So first thing, if you're able to see the slide, please let me know yes. So first question, every time when a slide comes is there'll be a question like how did you identify it's a liver biopsy, right? So for a liver biopsy, it's very, very simple. You have to go to the hexagonal architecture, and the most important thing in every liver biopsy is you look for this portal triad, the portal triad and the central vein, right? So if you look for portal triad and the central vein, that will help us definitely say yes, definitely it's a liver biopsy, right? You can see the artery, vein and the biliary radicle here. This is a perfect portal triad, right? So once I know it's a portal triad, it's undoubtedly, for sure, it's very, very simple for me to say it's a liver biopsy, right? If you look at this, you have an epithelial lining here. This is a portal biliary radicle. You have the artery here, and you have the collapsible venous structure here, right? There'll be more than one artery in a portal triad, right? So now I know it's a liver biopsy. Second, fat in any place, whatever part of the body. What's the color of fat? Come on, let's interact. You guys know you are the fag end of the entire second year. You must have definitely known this answer. It is going to be clear in appearance, right? So if you look at the hepatocytes here, first I'll show you a normal hepatocyte, then you look at a fatty liver part, right? This is how a normal hepatocyte will be, right? If you look at this, you have a row of an hepatocyte, then a sinusoid, again a row of hepatocyte, then a sinusoid, again a row of hepatocyte, then sinusoid, right? This is how normal liver will be. Normal liver cells will be pinkish in color. It might have one or more than one of nuclei, right? So now if you go to this part in the cytoplasm per se, right, can you see that there are empty vacuoles? Empty vacuoles in the cytoplasm, empty vacuoles. That's a simplest and the easiest description of fatty liver, right? So now since we know about fatty liver, I'm just going to take few words which might come in an exam. Causes, types. There are two types of fatty liver. One we call it microvesicular steatosis, the other is macrovesicular steatosis. If the question comes how do I differentiate micro and macro in a histopathology slide, in microvesicular steatosis the simplest one is the nucleus will be in the center of the cell. In the macrovesicular steatosis, the nucleus will be pushed towards the corner of the cell. If the nucleus is in the corner of the cell, the entire fat globulus push the nucleus to the corner. That's how it's macrovesicular and it's microvesicular, right? So causes of fatty liver. Can anyone comment on at least one cause of fatty liver? Fatty liver has multiple causes. First, I wanted to comment on NASH, non-alcoholic steatohepatitis or non-alcoholic fatty liver disease, NAFLD. Then obviously alcohol is one of the important causes. If the question is on a pediatric population, the fatty liver causes PEM, protein energy malnutrition, the Kwashiorkor marasmus, where all the peripheral fat will be diverted into the liver. That's the cause for pediatric cause, right? Okay. Now in the H&E, in a light microscopy, obviously fat will be clear in appearance, right? Definitely in a Viva, this will come as a leading question. Why is fat clear? Anyone? Come and interact. It's fine. If you make a mistake, it's not at all a problem, right? So the reason for fat being clear is fat will be cleared away during processing, right? So fat will be clear because it will be washed away during processing. So when I process a tissue, it will be washed away. That's why I always need a frozen section or a no fixative for me to look at the fat stains in microscope, right? There should be no fixative, or only when in a frozen tissue I'll be able to look at it, right? So once you're done answering all these questions, they might ask what are the special stains if you might know regarding fatty change or fatty liver. There are two stains I want you to remember. One is oil red O, where the fat will be reddish color, and we have Sudan black. You can call it Sudan Black B, Sudan Black 4, any different thing, but Sudan Black is more than enough, or SBB, Sudan Black B, is a fat stain, right? So these are few things which might be required from an exam point of view. This is what I'm going to do for every slide. Show the slide, a few identification points, why it is the normal thing and why it is abnormal, and few leading questions, which is more than enough for you to sail through the practical exam, right? Since you guys are very silent audience, this is the last day of this year, right? Maybe my last day of the lecture here for this year, right? We'll have one more lecture tomorrow as well. So slowly answer, keep answering. It's completely fine if you're wrong. Okay, so I'm going to show you the next question, next slide. Let's see if you can identify. There are two slides here, both of them are acute inflammation. Let's go to the first slide. I hope it opens. I'll give you the slide also for you so that you can easily appreciate them, right? Can anyone tell me what organ is this? It's a very simple organ. If an entire organ is seen in a single slide, that's an appendix. It's a tubular structure with a lumen with all the lymphoid follicles here. That's how an appendix looks, fine? Perfect. So if you look at the appendix, I'm going to zoom here. This is a normal slide or an epithelium of the appendix, simple columnar epithelium. Below that, we have the Peyer's patches or the lymphoid follicle. Appendix, if you know, there's only one thing which can be coming in an exam, which is acute appendicitis, right? So now, how do I say it's acute appendicitis? If your answer is saying that I'm having neutrophils in the blood vessel, it's not acute appendicitis. In normal blood vessel also I'll have neutrophils, right? The only way I can say it is go to the muscle layer. This is my epithelium, this is my submucosa, this is muscle, right? So in this muscle layer, if you zoom, you will see neutrophils in between the muscle layer. This is a muscle neutrophil. It's not there in the vessel, it's there in the wall of the appendix. That's the most important thing. For me to call it an acute appendicitis, I need neutrophils. Those are perfect neutrophils, right? You can see the bent nuclei, right? The perfect neutrophils in the wall of the appendix, then I can definitely call it an acute appendicitis, right? So that's the best way to call it acute appendicitis. Please don't go to blood vessel. In blood vessel, actually, if you can see, there's rolling going on in the blood vessel. Maybe it must have gone outside and must have infiltrated the entire wall of the appendix, fine? Okay, that's how you're going to say appendicitis. How do you know it's an appendix? If you have a luminal structure in a slide, right, along with that you have the lymphoid follicle, right? Lymphoid follicle tells us is definitely a lymphoid structure, your intestinal structure, and the entire lumen seen in a single slide has to be an appendix, right? Second, how do you know it's an acute appendicitis? For me to call it an acute appendicitis, you need neutrophils. We'll have the bent nuclei and neutrophils. Neutrophils will be in the wall of the appendix. If you have neutrophils in the wall of the appendix, that's a classical finding for an acute appendicitis, right? And you might have a leading question on events of acute inflammation, right? Okay, good evening. Samantha, it's not the diagram, I'm just having the slides here. Okay, these are slides here, Samantha. Good evening, Mohit. You have the epithelium, you have the Peyer's patch, and here in the wall of the entire appendix, you have the neutrophils. Then I can fairly enoughly call it an acute appendicitis, fine? Okay, perfect. So events of acute inflammation can be a leading question. You have to talk about margination, right? You have to talk a little bit about rolling, the selectin interaction and everything. You have to talk about addition, the integrins and your ICAMs and VCAMs, and obviously about diapedesis. They might ask you that, right? Some of your colleges might have one more slide for acute inflammation, right? I'm just collating slides from various colleges which students have given me, right? If I miss something, do let me know, okay? Unknown elite being, right? So see you soon after a couple of years. Once you come to second year, we'll learn about this, fine? Okay, now this is a simple slide of a lung biopsy. How do I say it's lung? If you zoom in, you can see a beautiful alveoli here, right? Actually, it's not a normal alveoli. Obviously, it's going to be a simple case of a bronchopneumonia. I'm sure most of his colleges might have this slides, right? So if you look at this is how the normal alveoli will be, an empty space, because normal alveoli is filled with air, right? But if you look here, can I say this entire alveoli is filled with neutrophils or inflammatory cells? Look at them. The entire alveoli is filled with inflammatory cells, right? Predominantly neutrophils, right? So this alveoli, will it be breathing? They'll not be breathing because I have lots of cells here, right? So this must be most likely consolidated alveoli where I have lots and lots of RBCs as well as WBCs, most likely a stage of red hepatization if I'm right? But we have to look at the gross to answer it. But this is how acute bronchopneumonia looks like. The entire alveoli filled with neutrophils, right? Okay, all the very best. Can anyone tell me any one organism which causes acute bronchopneumonia, right? So second slide, what we saw was an acute case of an bronchopneumonia. I cannot call it an acute broncho or lobar because broncho and lobar are both based on your gross architecture. I can just say it an acute pneumonia, right? Identification points. to say it's a normal lung, I go for the alveoli. Second, the entire alveoli will be filled with WBCs. Okay. If it's filled with WBCs, I can definitely say it's an acute bronchopneumonia. The other one is in chronic pneumonia, the interstitial pneumonia, where the lymphocytes will be then the interstitium. Here, the alveoli has WBCs and predominant of them are neutrophils. So I can definitely call it an acute bronchopneumonia, right? Klebsiella can cause, Streptococcus can cause, Staphylococcus can cause. There are multiple acute bacterial pneumonia causes. I'm sure you must be aware of, right? So 2 slides for acute inflammation, acute appendicitis and acute bronchopneumonia. Fine, perfect. Let's go to the next one. It's a very simple slide. This slide at least I want you to answer without looking at the label, right? Okay, let's go to the slide. Let's have a look at it. It's a lymph node, right? It's a lymph node here. Look at the lymph node. Can anyone tell me what structure is this? You should not miss the structure, right? It's a beautiful, beautiful granuloma. In the center of the granuloma, in this part exactly, I'm having completely pink color, right? So this is the caseous necrosis. And if you can carefully look at this, these are the elongated cells, little bit of elongated, maybe looking like a slipper shaped nuclei, the epithelioid macrophages, and the entire structure here is in granuloma, right? Definitely there'll be giant cells. We'll have to just scout for someone. Let's see if I can find any giant cell here. Can I call this a giant cell? I'm having 1, 2, 3, 4, 5 nuclei here. That's a giant cell, right? So that's a classical case of a necrotizing or non-necrotizing. Great, Srinath. Necrotizing, non-necrotizing. Look at this. That's a classical case of a necrotizing, right? Necrotizing. See, there'll be non-necrotizing granulomas also in the same image, but here predominantly I am having necrotic areas in the center. That's a classical case of a necrotizing granuloma, right? So it's a necrotizing granuloma in a lymph node. What's your diagnosis? It has to be tuberculosis. That's all, right? So it's a classical case of a necrotizing granuloma. So my first thought process, TB lymphadenitis. That's going to be my first thought process. How do I say it's a lymph node? The capsule is there, the architecture is there, that's what says a lymph node, or the history will have a lymph node biopsy, right? Cause of necrotizing granuloma, the first and the foremost thing is tuberculosis. Otherwise, very rarely I can have histoplasmosis or coccidioidomycosis causing it, right? The principal cell of granuloma, like Srinath said, the modified macrophages or the M1 activated macrophages or then epithelioid macrophages, right? That's the principal cell of the granuloma. There are 2 interleukins which are very, very important in granuloma. Can anyone tell me what are those interleukins? There are 2 very important interleukins which you have to learn with respect to a granuloma formation, right? One is interferon gamma. Interferon gamma helps in the conversion of a normal macrophage to an M1 activated macrophage. Then interleukin 12. Interleukin 12 converts T cells into Th1 subtype, because Th1 subtype is the one which secretes interferon gamma, again helps in the formation of the granuloma, right? There might be 2 extra questions they might ask you if you answer everything right? I just want you to tell me one answer. I'll ask a leading question to the answer. When you examine a patient of tuberculous lymphadenitis, what's the characteristic appearance of the TB lymph node? The very characteristic appearance in case of a TB lymph node, what is that? Is it like rubbery? Is it like matted? What do you call it? TB lymph node has this characteristic finding. Come on guys, you answer. You can answer. You know the answer. Please open the mouth. It's completely fine to make a mistake here. It is matted lymph nodes, right? So matted lymph nodes is a characteristic finding of a TB lymphadenitis where all the lymph nodes will be merged together. That's matted lymph nodes, right? So why there's a matted lymph nodes? TB lymphadenitis does not involve the substance of the lymph node also. TB also will have something called periadenitis. Let's see if we have the periadenitis in the slide, which means this is the lymph node. Surrounding the lymph node also inflammation spreads. That's why 2-3 lymph nodes joins together and gives the matted appearance, right? Let's go to the slide. If possible, if we are able to appreciate the periadenitis, let's see. Fine. Okay, let's go here. See, actually, these are 2 lymph nodes. This one, this is the second one, right? So if you zoom in here, I have a little bit of capsule here, but outside the capsule also I'm having inflammation. Same way, I'm having a little bit of capsule here. There's a gap, very defined gap. There's an inflammation. This inflammation outside the capsule is what is causing the lymphadenitis, right? Or the periadenitis. Again here, see here is a capsule, right? It's a capsule, but when you go here, a little bit outside the capsule also, inflammatory cells are very well seen, right? So periadenitis is a very classical feature of tuberculous lymphadenitis. That's the reason you have the matted lymph node. This might come in a waiver, especially if you answer everything correctly, right? Okay, next. Amyloid. Amyloid is a classical finding. Amyloid is nothing but is it starch or is it protein? What does it take? What's amyloid? They are perfect. They are beta pleated sheets. Okay, they are beta pleated sheets, non-branching beta pleated sheets. They are obviously proteins, right? Containing some of them. Okay, they are obviously beta pleated sheets. What will be the color of amyloid in a microscopy? Obviously, in the normal light microscopy, amyloid will be pink in color. Right? I'm going to show you a classical case of amyloid. I'm not sure what slide they showed you in your college, but I'm having a simple, superb case of a liver hepatic amyloidosis. Okay, let's look at this. Generally, amyloid gets deposited in and around the brachial, in and around the vessels, right? Amazing, Ashwin, right? It will be deposited in and around the blood vessels, right? So if it gets deposited in and around the blood vessels, this is a beautiful case of a liver, and you classically see you have the hepatocytes here, you have the hepatocytes here, hepatocytes. In between the hepatocytes, we generally had sinusoids. Here, entire sinusoid of the liver is pink in color because it is perivascular, the space of Deci, the entire sinusoid is becoming pink in color. All these extracellular acellular deposits are nothing but amyloid here, right? So since it's pink in color, most of the proteins are, many things are pink in color. There are multiple subtypes A, AL. These subtypes alone, at least don't forget. A for chronic inflammation, AL for your multiple myeloma related. If you answer well, they might ask A beta, beta 2M microglobulin, ATTR, and specific amyloids of your medullary carcinoma thyroid and others. Fine. These are few things which I don't want you to forget. Stain. There are multiple stains. Can anyone name at least one stain? The common stain, this is must know. Congorid is must know. In addition to that, you can answer thioflavin is a stain. It's a protein. TAS will definitely be positive, right? Crystal violet will be positive. These are all stains used. There are many more stains as well. That's not relevant in current brain practice, right? For practice, for me, it's congorid. And congorid in a polarizing microscopy, that will definitely be a leading question. You have your apple green birefringence, right? When apple green birefringence, it's a concept of light, that's all, fine. Amyloid is pink, extracellular deposit of protein surrounding the blood vessels, abdomen fat of a pad of fat biopsy is preferred because I have lots and lots of capillaries, right? Types and stains, that's all. Okay, next, fat necrosis. Okay, necrosis anywhere in the body, what will be the color? Pink or blue? Necrosis will be pink in color, necrotic tissue. Fat will be clear in appearance, right? So necrosis, we divide them into fat necrosis, we divide them into traumatic and enzymatic. Traumatic fat necrosis happens in any fat structure like breast parenchyma or the gluteal region whenever you had trauma. Enzymatic fat necrosis happens in omentum and the peripancreatic fat in case of an acute pancreatitis, right? Perfect. Now let's look at the slide. Okay, fat necrosis also in microscopy will look pink in color only, right? See, this is an omental biopsy. Okay, can I call this fat? Adipose tissue? Definitely a simple normal adipose tissue. This is how adipose tissue looks like, right? Now, if you go a little bit higher up, look at this. I do have good amount of adipose tissue here, but if you carefully look, these places also must have been adipose tissue, but it's been destroyed. The triglycerides has been converted to free fatty acid and it's becoming pink in color, right? I'm just going to zoom out here. All these pink areas here are nothing but necrotic fat, and all the clear areas in between the necrotic fat are still live adipose tissue. Fat necrosis in microscopy also looks pink in color only, it will not be clear in appearance, right? The reason for pink color in case of fat necrosis, the triglycerides in the fat will be converted to free fatty acid, and that will obviously change the color from clear to pink. It will not be washed away, it gives a pink appearance. In microscopy, obviously it will be pink in color only. That's a classical finding case of fat necrosis. Can this fat necrosis give rise to calcification? That might be a leading point because Robbins talks about that and people want to hear this name somehow. Saponification, right? You will never forget this, right? Soap formation, calcium salt formation happens only in fat or every necrosis? Every chronic necrosis happens, especially in fat necrosis it happens, that's all, fine. Okay, next, lipofuscin. Okay, first let's look at the theory part, then we'll go to the slide here just for a change. What will be the color of lipofuscin in a microscopy? Pink, blue, brown, black, brown. Okay, when I say brown, I know for a fact melanin is brown, hemocyte is brown. There's one classical location of lipofuscin which helps me to identify its lipofuscin. What's the location? Is it perinuclear? Is it throughout the cell? Is it perimembranous? It is perinuclear. A perinuclear brown pigment in an elderly person is generally a clue There are few places where liposuction can be very commonly seen as heart, liver, pancreas. It can be seen in many tissues, right? Cardiac muscle or any straightened muscle, liver, pancreas, you can have it, right? Yes, Sakar. The calcification will look blue in microscopy, but the necrosis will obviously be pink in microscopy, right? And it's seen in any old age person. Young person also can have liposuction, but generally in an exam, age is the most important criteria for us to pick up liposuction, right? This is a cardiac biopsy. You look at the slide. It's actually a post-mortem cardiac biopsy, just stored for us to look at liposuction. Okay, let's zoom. Can you guys see the liposuction? It's much better than the image what you saw on Robbins, right? So many liposuction. Perinuclear, 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 right? Perinuclear. Okay, as a classical perinuclear deposit, right? All these, look at this, look at this, look at this. Perinuclear, perinuclear, right? Golden brown pigment or brown pigment, perinuclear in location in an elderly heart, which made it called as a brown atrophy of heart, and everything might be relevant from a Viva point of question, right? It can, the reason for liposuction pigment is it's a pigment of cells aging. It's also called as an wear and tear pigment, right? It can be seen at the end of acute inflammation. It's nothing but an injured cell where all the broken particles been just been contained back. And the reason for liposuction is that they are nothing but autophagy related, autophagic lysosomal remnants. That's all, right? Autophagy is the reason primarily for liposuction granules, fine. So we know about liposuction as well. Okay, let's go to a simple normal coagulated necrosis. Okay, how do you identify necrosis? Coagulated necrosis. One main difference between coagulative and liquefactive necrosis: will it retain the architecture or there will be no retained architecture? Coagulative will definitely have retained architecture, right? So coagulative necrosis, obviously first thing, it will be pink in color. Second thing I can say, there will be retained architecture of the cells. Okay, if you have retained architecture or the ghost cells present, right, I can definitely call it a coagulative necrosis. Causes, you know the answer by now, right? Any solid organ infarct. Any solid organ infarct will have coagulative necrosis. Can be cardiac, can be kidney, can be spleen, anything. Any solid organ have infarct will be coagulative necrosis. The mechanism of action of coagulative necrosis is protein degradation. That's a main mechanism of action of coagulative necrosis. Okay, now let's look at a slide. This is the most likely slide you must have also got in your college, but I'm not sure what they kept for coagulative necrosis. Can you guys tell what was the slide which is kept for coagulative necrosis for you? Okay, it's open. First tell me what tissue is this. If you tell me what tissue is this, then let's go to coagulative necrosis. What tissue is this? What tissue is this? That's a classical glomeruli tubule, right? So this glomeruli and tubule, it is live, perfect, right? Glomeruli tubule, kidney, because I can see the nucleus, it is definitely live here, right? Now let's go a little bit ahead. Let's go see, this is a beautiful area. Can I say this part is more pink? Definitely gone, necrotic. This part is live, this part is pink. Let's go to the pink area. Is it retained cellular architecture? Definitely. These are tubules, but they are dead because it's completely pink in color. Pink in color, retained cellular architecture, I can definitely call it a coagulative necrosis, right? Let's look at few of the necros glomeruli if there are anything there. Look at this. Necros glomeruli, it's perfectly a glomeruli. Architecture is perfectly retained, but there's no cells at all, no live tissue at all. That's a classical retained cellular architecture, right? So this entire part is necrotic. If you go here, we do have the live tissues here, right? That's necrotic and live tissue. That's a classical case of a coagulative necrosis, right? Liquefactive necrosis, I cannot see this difference. The entire architecture will be gone. The mechanism of action is definitely an enzyme activation. Your brain infarct, abscess formation, anything with suppuration, you'll have liquefactive necrosis, fine? Okay, then cholestasis. Identification points. First, it's a chronic condition in the gallbladder. It's chronic gallbladder infection or cholestasis or chronic cholecystitis. So here, what I'll have is, in the lamina propria of the gallbladder, I'll have lots of macrophages filled with cholesterol crystals. Cholesterol will be clear in appearance, right? Lots of fat-laden macrophages. So I have lots of fat-laden macrophages. That's a classical finding for cholestasis. And in gross, can anyone tell me what's the name given for cholestasis in gross or a naked eye? I want you guys to comment. We look at the slide and let's come back to this here. Okay. So how to say it's a gallbladder? The mucosa. The mucosa, the wavy mucosa, and not much of a thick wall and lots of periserosal fat tells is a clear gallbladder, right? And now let's go here. The space immediately below the mucosa is your lamina propria, right? So in this there's a mucosa here or the epithelium here. Below the epithelium I have lamina propria. The entire lamina propria is filled with fat laden macrophages or cholesterol laden macrophages, right? So the easiest way to differentiate cholesterol versus fat or triglyceride. Cholesterol will not be as clear as your fat. It'll be like kind of bubbly. This is how cholesterol looks, right? We saw fatty liver that is completely clean. We saw the fat necrosis is completely clean. Cholesterol have a little bit of tiny bubbles. They're also clear, but tiny bubbles. These are all cholesterol laden macrophages, and this gives in gross yellowish in color. The red mucosa gives the appearance of a strawberry gallbladder, right? Look at this. This is also a lamina propria. This is also a lamina propria. Maybe not much of them here. Here again, there's a lamina propria full of cholesterol laden macrophages, right? Okay, that's how cholesterols looks like. It's also an accumulation of the fat. Okay, in gross you'll have a classical appearance of a strawberry gallbladder, the yellow color for the fat and the red color for the classical gallbladder appearance. Okay, great, perfect. Next, CVC liver. First, tell me what's the gross finding here. We'll definitely look at the microscopic findings. All of them, whatever you have read, will definitely be seen in the slide. Gross, you have the classical nutmeg liver. CVC liver can also be called as cardiac cirrhosis. Great, Luffy. OP Luffy. Luffy is a cartoon character, right? Great. So cardiac cirrhosis. Fine. So cardiac cirrhosis is the other name for it. Nutmeg liver is the finding is seen in gross. How do I identify in microscopies? Your fatty liver or CVC liver or chronic venous congestion of the liver will definitely have congestion surrounding the third zone of the liver, which is centrilobular, right? So here you'll have centrilobular hemorrhagic necrosis. So centrilobular hemorrhagic necrosis, especially the zone 3, is classical for a CVC liver or chronic venous congestion of the liver, right? Causes anything above. When you have a problem with the heart, right heart failure, most common cause of right heart failure is left heart failure. Any heart failure, the back pressure kind of goes through the IVC, goes to the hepatic vein, goes to the central vein and comes and destroys the centrilobular. Centrilobular is nothing but surrounding the central vein of the liver, right? Okay. So it's hemorrhagic necrosis. So you'll have hemorrhage as well as necrosis. Nutmeg liver reason is that the normal thing gives an tan appearance of the liver, and a hemorrhagic area will have reddish appearance in the liver. So it has an alternate tan and reddish area which looks like a nutmeg, right? Let's see if we can find all the classical findings in this slide. Okay. It's a liver biopsy. Again, how do I say it's a liver biopsy? I have to go to this guy, the portal triad, right? If you look at this, there's a beautiful portal triad here. Biliary radical, compressed vein, maybe an artery here, right? That's a portal triad. And whatever is seen next to the portal triad is zone 1. Zone 1 is relatively normal. Zone 2 is decent. But when it comes to zone 3, look at the amount of hemorrhage here. Completely hemorrhagic, right? Entire area is completely hemorrhagic. So everywhere, portal triad, again a portal triad, right? A beautiful portal triad. The zone 1, zone 2 is normal, zone 3 is gone. Again a portal triad, zone 1, zone 2 is normal, zone 3 is gone. Right, and here you can see a classical dilated central vein, right? Let's zoom this here. A central vein and lots of hemorrhage here, and also the entire liver cells also dead, right? Hemorrhage, death, hemorrhagic necrosis, goes to zone 2, it's decent, goes to zone 1, it might even look normal, and your portal triad, right? So that's a classical case of a hemorrhagic necrosis or a CVC liver, chronic venous congestion of the liver. Portal triad, surrounding the area will be normal, little bit far away from the portal triad, again hemorrhagic necrosed, again hemorrhagic necrosed. If you zoom out, if you can imagine, if you zoom out, all these red areas will look, gives the nutmeg appearance. Red pale gives the classical nutmeg appearance or a CVC liver, right? Okay, great. Thrombus. Thrombus, I am not sure if they have shown you or will they show you in exam, but it's a very classical finding which you have to see. How do I say it's a thrombus? This can come in an exam. How do I say it's a thrombus and not an embolus? Because both of them has more or less the same appearance, right? So first let's look at the image and then let's come to the classical findings here. It's a blood vessel, classical blood vessel. You can see, though I am not able to differentiate intima, media, adventitia, but this is a wall of the blood vessel, right? So now The most important characteristic feature for me to call it a thrombus is it has to be attached to the blood vessel wall. Embolus is moving. They will not be attached to the blood vessel wall. If it's attached to the wall of the blood vessel, it is a thrombus. If it's moving, it's an embolus. Okay, that's the most classical finding here. And if you look at this place, you can actually look at the, I'm not sure, it's not very well defined, but definitely a reddish area, a pale area, a reddish area, a pale area. What is this call us? Maybe we'll look at the other area if it's much better. Maybe a decently better one, right? Reddish pale, reddish pale. What are these lines called us? We call them lines of Zahn. Perfect, Sarthak, right? If you have the point of attachment to the blood vessel, I can definitely call it a thrombus. If it's not attached, if it's floating, I'm going to call it an embolus. These are the classical lines of Zahn. Please do remember, lines of Zahn is seen both in arterial and venous. It will be less evident in venous, but both of them will have. Lines of Zahn present means it's an antemortem thrombus, which means the blood is flowing. When the blood flows, I can see the altering areas, right? The red areas here are the RBCs. The pale areas here is the platelet and fibrin. The platelet and fibrin and the RBCs, which is going from the lines of Zahn. The lines of Zahn grossly also has a different architecture, different color. Because of that, it's called a coralline thrombus. Thrombus name coralline thrombus. It looks like a coral, right? It's altering color. It's called a coralline thrombus, and that's the microscopic equivalent of lines of Zahn, right? So identification, the most important thing, like Sarthak said, the point of attachment to the vessel. The biggest difference between a thrombus and embolus is embolus will not be attached to the blood vessel, and thrombus obviously will be attached to the blood vessel. You might have embolus of your fat embolism or an amniotic fluid embolism. You might have cases. I don't have a slide of fat or amniotic fluid embolism, but this is how a thrombus looks like. Fine. Okay. Just a simple finding. In the same slide of thrombus, I'm going to zoom into a different area. That's all. Look at this area. What is this? Anyone? Sorry, what is this? Blackish pigment in a lymph node, right? This is a perihilar lymph node. This is actually the pulmonary artery. If you can look at this, the cartilage and maybe the overlying epithelium mucus, this might be the bronchial area, and this is your pulmonary artery thrombus, and this is your hilar lymph node. A hilar lymph node having a black color, it's a classical, like Sunny said, it's a carbon particle. It's a classical carbon particle, classical case of anthracosis, right? Anthracosis, the only place where in microscope you'll have black color is anthracosis. It can be seen both in the lung as well as in the hilar lymph node. It will be completely black. Actually, what is seen in microscopy is black color pigment in the macrophages. In worst cases, it can also be seen in interstitium, but most of the time it will start with black color pigment in the macrophages. That's a classical appearance of anthracosis, right? Anthracotic pigment is classical, and anthracosis is not an occupational lung disease. There's a part of coal workers pneumoconiosis. Anthracosis, you and me, everyone can have, like anyone who's living in an urban area can have, anyone who smokes tobacco can have. Then you have simple coal workers pneumoconiosis, and we have complicated coal workers pneumoconiosis. Those are the complications of the occupational lung disease. This neither of us will have. If you're not working in a coal mining industry, I might not have this, right? Okay. Hemangioma, just few more slides. I hope hemangioma also is a part of the in general pathology in the last chapter, so I'm including it here. Okay. Two things, capillary versus cavernous. How do I identify? In a capillary, it will be very difficult for you to identify the hemangiomatous structure. You'll have very tiny capillaries. These capillaries might not be dilated. It will be almost similar to a granulation tissue. Granulation tissue and a capillary hemangioma is very difficult to identify, differentiate. If you have an overlying ulcer or an inflammation, it's a granulation tissue, because granulation tissue also have very high capillaries. It will be very similar, right? Cavernous is spotter. Cavernous, even a low power, you can identify there will be lakes of blood vessels. There will be huge areas filled with blood. That's how the cavernous looks like. This cavernous is spotter. You need not want anyone to say it's a cavernous hemangioma. Look, it's a low power image. That's beautiful cavernous hemangioma, right? Superbly dilated vessels, vascular spaces filled with blood. little bit of in between intervening thick septa, all the classical of a cavernous hemangioma. You can see them in the skin, subcutaneous tissue, liver, anywhere, right? Capillary on the other hand might be a bit difficult. Okay, so here there are few dilated spaces here. Just because there are few dilated spaces, don't call it cavernous. The most important thing is in this part. If I zoom in here, all these tiny gaps, all these are individual capillaries. This is how dense capillary hemangioma will be. It might be, like I said, bit difficult to identify. Here one thing which comes handy is the slide number, right? Look at the slide number, because capillary hemangioma is a bit difficult. These are all these empty space. Can you see the RBCs here? All these are dilated capillaries, right? That's how capillary hemangioma look. But cavernous, like I said, is a spotter. You cannot miss a cavernous hemangioma. Capillary hemangioma is a bit difficult to identify, so please be careful about it. Okay. Leprosy, the last slide here. Did they show leprosy slide for you in your college? We have two different types of leprosy here. One is your tuberculoid leprosy. Tuberculosis like where the immunity is good, right? And we have lepromatous type of leprosy. In lepromatous type of leprosy, the cell-mediated immunity is poor. In a tuberculoid leprosy, it will form granulomas, mostly non-necrotizing granulomas, especially in and around the nerves. You can have necrosis, otherwise non-necrotizing granulomas, right? In lepromatous leprosy, what I'll have is I'll have sheets of histiocytes. Histiocytes are the other name for macrophages filled with leprobacilli. That's how it looks in lepromatous leprosy. Okay, they're not shown. Great, let's ignore it. It was there in the NMC curriculum, so I took it. Okay, so if you look at this is skin biopsy, and all these things are macrophages. These are all macrophages, right? Classical macrophages here. One important finding, if they have shown you the slide, which can easily appreciate here, is the macrophage here never touches the epidermis. The macrophage here, the clusters of macrophage never will touch the epidermis. This area is called as Grenz zone. Grenz zone is the area where the macrophage or the infectious organism will not go and touch the epidermis. It will be totally different from the epidermis. It's in the dermal space only, and this space is called as Grenz zone, and these are the sheets of macrophages with leprobacilli, right? Just since we are leprosy, I'll add few more findings. There's a stain called as Phyte-Farraco stain. Phyte-Farraco stain is kind of an acid-fast bacilli stain which is done for leprobacilli in case of a biopsy, right? That's all with regards to leprosy, right? So we have seen quite a few slides here. I think around 14 slides. Fatty liver we saw. Acute inflammation we had 2 slides. Appendicitis and bronchopneumonia. Granulomas, a perfect TB granuloma, and also we read about tuberculosis. Amyloid, a liver amyloidosis. Fat necrosis, simple normal momentum. Lipofuscin biopsy of cardiac tissue. Coagulative necrosis of the acute tubular necrosis of the kidney. Cholestasis of gallbladder. CVC liver, a very classical slide. Thrombus of a pulmonary artery. In the same image, you also had an anthracotic lymph node. We saw 2 types of hemangioma, capillary and cavernous, and we ended with lepromatous leprosy, right? I'll share this PDF in the Insta channel or in the PW Telegram group. This will also have the slides. Just whenever it's possible, just have a quick go through it, right? Tomorrow's class, I'll take same way, little bit of cases from hematology. The third day, we'll have little bit of cases from systemic pathology, right? It will be great if you guys can ping me what are the slides which comes in hematology and systemic part. So I'll just concentrate on that a lot, right? Thank you, Srinath. Thank you, Sarkar. All the very best for your practicals. Okay, see you soon.